The pathobiological spectrum of COVID-19 is manifested in three distinct clinical phases. The first phase of COVID-19 is hypoxia. The binding of SARS-CoV-2 to ACE2 receptors on host cells reduces blood pressure, lung function, and lowers oxygen availability, which causes hypoxia. Hypoxia affects oxidative phosphorylation in mitochondria and alters host energy metabolism. This hypoxia-induced clinical condition is triggered by iron-regulated host metabolic reprogram or HMR. HMR affects body's energy requirements for immune defense, aggravates inflammatory responses, and causes tissue damage. The second phase of COVID-19 is hyperferritinemia. Severe SARS-CoV-2 infection with dysfunctional immune response is linked to iron redox dysregulation or FERD. FERD in COVID-19 is reflected by high iron content in reticuloendothelial cells with elevated serum ferritin levels, which leads to hyperferritinemia and cytokine storm. Phase 2 COVID-19 is considered a broad spectrum hyperinflammatory disease amplified by cytokine release syndrome or cytokine storm. The final third phase of COVID-19 is thromboembolism. SARS-CoV-2 could invade blood vessels, induce vascular damage, and modulate several pathways of blood coagulation. Iron toxicity from oxidized iron due to coagulopathies along with FERD could trigger severe to fatal thromboembolism in COVID-19. Hypoxia combined with thromboembolism causes hemolysis, releasing heme proteins that accumulate free iron in the plasma. Hemolysis-derived heme could trigger oxidative as well as inflammatory stress with multi-organ dysfunction syndrome or MODS in severe COVID-19.